Good evening and welcome to the fourth broadcast of the Rheumatology Nurse Practice Google Hangout. And we'd like to welcome everyone tonight. This is our first nighttime broadcast, and it's been just such a great year, these past three broadcasts, and then also if anyone caught the live broadcast we did from the regional meeting in San Diego, we just want to thank everyone for your great feedback, the input that you have, the support that we have. It's just been an incredible year for the Rheumatology Nurses Society. I'm Kevin Lyons. I'm the Executive Director of Rheumatology Nurses Society, and tonight we're continuing our series on managing RA throughout the lifespan. This is a series that is funded by a grant from Pfizer, which we deeply appreciate the support and the funding for that grant for this quality education that we're putting together. But what we have is we have peer-based education in a couple of forms, part of the Rheumatology Nurse Practice Initiative. A lot of the live broadcasts and the live meetings are based upon a booklet that we've put together called What Our Patients Are Asking Us About Rheumatoid Arthritis, and this is available free at our website, which is rnsnurse.org, and a lot of the conversation stems from the evidence-based newsletter that we produced called Rheumatology Nurse Practice. And this latest issue that just came out just a few weeks ago it's a phenomenal issue. It goes into a lot of the therapies available for RA, and if you get one or if you go to our website, we'd love to send you one for free. It also has a pull-out of all the drugs that are available, both the biologics and the DMARDs for RA. So we're very excited about that. But without further ado, I'd like to introduce our panelists tonight and our faculty. First off, we have Iris Zink. She is a nurse practitioner from Lansing, Michigan. She also happens to be the RNS president. We also have Elizabeth Kirchner. She's a CNP at the Cleveland Clinic, and she's our Curriculum and Education Committee Chair and RNS board member. And tonight we're really pleased to have a dear friend of RNS, Christine Stamatis, DNP ANPC. And we'll start with you, Christine. If you want to just say hello and introduce yourself, we'd love to hear from you and go around the table, and then we'll get started with our presentation.
Hi, I'm Christine Stamatis. As you heard, no, maybe you didn't. Anyway, I'm sorry. I'm from New York. I'm from a new health system called the Northwell Health System, previously the North Shore LIJ. And I'm very excited to have been invited, and I love the topic, RA through the lifespan. And now we are, on this session, going to be focusing on the older patients.
Betsy, would you like to welcome the audience?
Hi, I'm Betsy. I am a nurse practitioner at the Cleveland Clinic. I've been there about 16 years and just very excited to be here.
Awesome. And Iris.
Hi, everyone. Welcome back. I'm Iris Zink, your nurse practitioner, president of the Rheumatology Nurses Society from Lansing, Michigan. This is not what it looks like outside. I have a lovely backdrop with me tonight because of the snow outside, but the palm tree in here. So welcome. We're going to get started.
She tries to connect with me. I'm based out of Sarasota, Florida, and so I take a lot of grief over the fact that our backyard looks very much like that. So only a couple more months and you'll see some sunshine again. We'd also like to let everyone know that this is an interactive session. Not only will this session be recorded and turned into enduring content, which you can view on the RNS website, but also this session is live, and we have three ways that you can ask questions and interact with our panelists. First off, there's a Q&A feature on the Google Hangout on-air platform. So if you're watching this broadcast from the Google Hangout platform, there should be a Q&A. If you can also go to Twitter and use hashtag RNP16. Now, we were notified that RNP16 has something to do with Italian soccer as a hashtag on Twitter, but we'll feed through or go through that and we'll find your questions. And then you can also text us at 267-689-8495. That's 267-689-8495. You're welcome to text your questions in. So without further ado, let's jump right into our topic. We're going to be talking about the geriatric patient as we go through treatment trends in RA. So you can see a slide about the newsletter. Definitely sign up on the website, get that latest copy. There's also going to be a digital copy that will be released on the website sometime this week, so you'll have that access as well. So let's dive into our topic.
All right, Betsy, get us started, please, with the treat to target information.
I sure will. So I thought this was a fabulous issue. It was very meaty. There's a lot of good stuff in there. There were two sort of subtopics that really caught my eye. The first was treat to target, which is pretty self-explanatory. It was introduced as a formal thing in about 2010. It was updated in the ACR guidelines just last year. And the overall sort of flow of it is, it sounds pretty simple, but it might not be as simple as we think. So the first thing you have to do is set goals with your patients. That's the important thing. You have to do it with your patient. If your goals are different than what your patient's goals are, you're not going to get very far. The second thing is deciding what to measure, and honestly, in the big picture, it probably doesn't really matter. You can use Rapid3, you can use DAS28-CRP, you could use Vectra. There's lots of ways you can measure, but the important thing is to decide what you're going to use, and then the third step, which is to actually use it. Every visit, if you can, just keep measuring and tracking your patients and seeing how they're doing. And then importantly, you don't just sort of sit on that information, you need to adjust. And that's really where the shared and informed decision making comes in. If the side effects, if you do need to adjust medications and the side effects that we as clinicians might think are minor, if they're not minor to our patients, then they're not going to take the medicine and they're not going to reach their goals. And so we just keep doing this over and over, never stop measuring, never stop checking, and just try and get our patients all to target. So then the next thing that caught my eye, thanks Scott, was the drug tapering section. And that also, it sounds pretty logical and self-explanatory. Treat to target, the focus is sort of, we don't want to undertreat anybody. We don't want disease advancing, and we don't know about it. The drug tapering is more of, we don't want to overtreat. These drugs are powerful, they're wonderful, we love that we have them, but they do have side effects. They have costs, both financial and otherwise. So if we can get some really solid information on when it's safe to taper our medications, then we can avoid overtreating patients. I was going to talk about etanercept and adalimumab. Both those studies are in our newsletter. And I just decided at the last minute, instead I'm just going to focus on etanercept because something there really I think is fascinating. So in the newsletter, there's a nice description of the PRIZE study, which was an etanercept trial. And what they did basically is they put patients on a pretty common regimen, etanercept, methotrexate. They kept them on it for a year. The patients that went into remission then had their etanercept cut in half. So they got 25 milligrams a week plus their methotrexate. Oh, I'm sorry, there were 3 arms. One of the arms did that. The other arm got just methotrexate. They were still giving themselves an injection, but it was placebo. And the third arm was double placebo. They weren't getting any treatment. And as you might expect, 68% of the patients who were still on etanercept and methotrexate stayed in remission, 40% of the methotrexate only, and then 23% of the dual placebo, the no treatment, stayed in remission after another 39 weeks of doing that. So, you know, it sounds great. Yeah, you do the best on dual therapy, which makes sense. We wouldn't use these drugs if they didn't work. But the thing that caught my eye, and here's where I want to start opening up to discussion to you guys and to Christine and Iris, is that, I mean, look at that, 23% of patients, so they got into remission, they were on standard therapy for a year, they got into remission, however they were measuring it in the PRIZE study, and then they went totally off medicine, and 9 months later, they're still in remission. So it's really kind of thought-provoking. We're not advocating taking everybody off medicine, but if, you know, Christine and Iris, whoever wants to jump in here, if for whatever reason you had a patient and they had to go off medicine while they were in remission, now flip it back to treat to target. Would your target change? You know, how often would you be checking, and what kind of things would you be looking for, and would you check them more frequently? You know, anything like that. What do you guys think?
So if you want, I can talk first.
Yeah, that'd be great.
Okay, sorry about that. So the first thing that I would do is I would sort of look at the kind of patient I have and understand what they came into the beginning of their treatment with. So for example, if they came into treatment with really high markers of inflammation and very high levels of CCP and rheumatoid factor and multiple joints that were swollen, I would try to probably counsel my patient to be not as eager to be as quick at taking all medication off. And I would certainly, in either case, say that if we're going to taper the medication, we'll do one thing at a time, and we'll recheck you every 1 to 3 months. So that's pretty much how I would approach that issue. However, if someone came in and they did just have a few joints and they had a very low positive CCP, or maybe not even a positive CCP or rheumatoid factor, that person, at least by the literature, has been shown to be more likely to be able to successfully come off treatment.
How about you, Iris? What would you do?
I completely agree with Christine on this. That there seems to be many different types of rheumatoid arthritis, and you really just got to play it by ear. I try to encourage my long-standing patients who've been on biologics just to start spacing out their drugs. So if they were on Enbrel every week, I would just have them go Enbrel every 10 days. See if they can go Enbrel every 14 days and kind of just pull back. I have my patients fill their prescriptions on time because I don't want the insurance company to know we're trying this as an experiment, because I don't want the medication to be taken away, because so many of my patients can't stay in remission when they're off biologic. They just go right back into active disease. And so we try this sort of as an experiment where they just start pulling back. And I really have not had much success, although I do have some patients who just don't have to take their drug as frequently.
The only thing I want to comment on when we do change the frequency, especially in biologics, is that if you end up making the frequency too far in between, you actually can increase the chance of antibody formation and then allergic reactions and ineffectiveness of the drug. So I always counsel my patients, there's a limit to how far we can separate your dosing when it comes to the injectable agents.
So would you guys keep methotrexate on board then to try and prevent that sort of antibody development?
But I would in that case. But my understanding, at least from what I'm reading, is that really you're better off removing the DMARD and keeping the biologic on. If you were going to pick one drug, it's looking like you're better off keeping the biologic and removing the oral DMARDs. At least that's my understanding.
Which is right, exactly opposite of what Europe does. But I think the problem in America is we're treating so late that we have trouble achieving the same remission rates that they do in Europe.
Right.
Yeah, I think remission in Europe is a different animal than remission over here.
So can either of you talk about that? Are they really treating I thought that they were getting on board with the biologic therapies at a much later rate in Europe.
No, that's not my understanding. What about you, Iris?
My understanding is because they have the early arthritis clinics run by nurses, PS, and so the patients are getting diagnosed quicker, and then if they have real deal disease, they're getting on biologic quicker, so that their remission rates are actually much better than ours are, where we have a 6-8 month wait to get into rheumatology in the United States, and patients just are not getting onto biologics or being able to stay on biologics because of the switching of insurances and, you know, the blocking that goes on.
Right.
And they have the newer, not exactly new anymore, definition of early RA now that came out of Europe. It used to be anything less than 2 years. I think now it's down to 6 weeks. If you've gone past 6 weeks with symptoms, you're already past early RA.
I thought it was 6 months.
No, it was 6 months, and now they're, well, I guess in the research they're saying 6 weeks, maybe not in the definitions coming out of EULAR, but yeah, it was 2 years and it was 6 months, and then now it's going down to between 6 weeks and 12 weeks, where they're saying beyond that you've sort of lost your early treatment window.
Which, if you're talking 6 weeks, you're talking about getting to these patients well before they ever show up into rheumatology.
Yeah, pretty much.
Okay, Betsy, what do you want us to think about next?
Okay, well, so let's not talk about the tapering scenario anymore. Let's just talk about treat to target. Do you guys have a favorite disease activity measurement that you use, or one that is sort of more practical in a real world setting? Christine?
Yes, so I wanted to, when you were talking about this before, make everyone aware of most EMRs now can incorporate various disease activity scoring systems, whichever one you want to choose. And if you, for some reason, don't have that, you actually, there's many apps that can do the same thing. But I find the CDI, which I'm probably not saying it right, the Clinical Disease Activity Score, I find that to be very easy to use, and I can almost calculate it in my head without ever having to even look at anything. So from a ease of use, that's sort of my favorite. But before I leave this topic, I have to say that it's very frustrating when you're counting painful joints that aren't in fact swollen and may in fact be due to another reason, which is something that we'll be talking about when we talk about our case study later, so I'll end there for now.
How about you, Iris?
At my particular clinic, we do an S-dye and a C-dye on every single patient, which is redundant because I use the Vectra. And really, the Vectra, I find 90% of the time to be accurate. Now, 10% of the time, I don't agree with what the Vectra is saying, or it just doesn't work for that particular patient. But I think 90% of the time, the Vectra tells me the information that I need to know. So it just depends on what you're finding out there.
Betsy, what about you in the Cleveland Clinic?
We don't have one that, that they force us to choose one. The physicians I work with most regularly, and in my own clinic, we try and use DAS28. And I have to say that, our intentions are great, and we're doing it because we're a research facility and we have all these fellows running around. But CDI, like you said, Christine, it's a lot easier just to just do it every visit. I would say with our DAS28s, we're shooting for 100%, and we're not quite getting there. But we also use Vectra, and we also use, checking for radiographic progression. We try and get X-rays. Depending on the patient, if they came in with erosions, then it'll be more frequent. If they never had erosions, then we probably won't do them as often.
So when you say more frequent, how frequently would you take X-rays? Because I would typically think I would do them every 6 to 12 months. Would you do them more frequently than that?
No. If somebody came in with early erosions, then while we're trying to get them into remission, 6 months, and then in another 6 months to make it a year. Once they're in remission, if they've been in unstable therapy and they're doing well, then those patients we try and send for just plain films, hands and feet, every 2 years.
Yeah, that sounds perfect. Okay, what about a case presentation? Christine, do you happen to have one there with you?
I actually do. And so when I was putting this case study presentation together, what I kind of did is I melded probably 50 different patients together. And then thankfully one of them just came into my office last night. So this is a 72-year-old woman who is new to our practice. She comes in with already a clearly diagnosed seropositive rheumatoid arthritis that she's had for more than 30 years. She has erosive disease with multiple deformities of both her hands, feet, wrists, elbows. She's had bilateral knees replaced. She's had her right elbow replaced. And she reports widespread pain, overwhelming fatigue, stiffness, as well as swelling in both feet and some shortness of breath. So that's her chief complaint, which is loaded, if you might add. Her history is significant for having had an MI. She has had congestive heart failure. She has type 2 diabetes, and I need to go to the next slide. She's on multiple medications. She's on methotrexate, 10 milligrams per week, and has been on that for many years. She's on folic acid, hydroxychloroquine, 400 milligrams a day, also has been on that for many years. She gets her eyes examined on a regular basis and has never had an issue with that in the past. And since her MI, she's been on metoprolol, 25 milligrams twice a day. She's on warfarin for her atrial fibrillation at 5 milligrams a day. She's also, with her type 2 diabetes, is on metformin. And her hemoglobin A1C is not fantastic. It's around 8. She's on atorvastatin, 10 milligrams, furosemide, 20 milligrams a day with potassium replacement. She has difficulty sleeping, largely due to the chronic pain that she lives in and the anxiety about just getting through every day. So she takes alprazolam every night and also is on routine oxycodone. Before you change that, I just wanted to say on the oxycodone, she uses at this point 4 to 6 a day and is not well controlled. As you saw at the beginning, she came in with a significant amount of pain. She has some other review of systems. So she suffers from dry eyes and dry mouth with a full set of dentures. She has progressive dyspnea that interferes with her daily activities significantly. And she reports frustration with that and a difficulty in walking and being able to care for herself. She has a dry, non-productive cough and has not had that really evaluated, except that she says her cardiac situation is under control. She has chronic reflux and is on proton pump inhibitors on a daily basis. I don't know if anyone saw the recent research from JAMA that came out a few weeks ago that's very interesting regarding that. She suffers from some mild constipation as a result of the narcotics, and then she's also in the past has had elevated liver functions, although recently they've been normal, and as you would imagine suffers from some chronic kidney disease that vacillates between 2 and 3. As I mentioned before, she is got atrial fibrillation at a controlled rate at this point. On skin, she does have rheumatoid nodules on her forearms, and she bruises easily. The rheumatoid nodules are important in that they help to indicate that this is probably a more aggressive and severe form of rheumatoid arthritis, which we know from her deformities at this point. She also suffers from some peripheral neuropathy in her hands and feet, severe at times. She's got some cervical radicular pain in her right arm and into her fingers. And a little bit of weakness in there as well. And her sleep is described as non-restorative. She has trouble staying asleep because every time she moves, she has pain somewhere, and frequently complains of pain in her back as well. Whew.
So, Christine, did you say that she had never been on a biologic before?
I did not say that she had never been on a biologic before. I did not go into any of that. I gave you what I know so far, but no, she has been on multiple biologics. She's been on Humira, she's been on Enbrel, she's been on Actemra briefly, but she ended up having some GI symptoms from that, and also ended up down the road developing diverticulitis, so then we didn't want to have her be on the Actemra anymore. I can't say Actemra, I meant to say tocilizumab. So the drugs she has not been on are Orencia or rituximab at this point.
Okay.
So the question is really, and the very first thing that we have to determine is how much of her complaints of pain and stiffness are related to active disease and how much are related to the fact that she has multiple deformities and has cartilage loss in many, many different joints and probably suffers from chronic pain as a result of that. So I think I want to throw out to you all, what would be some of the first things that you would do to try to discern this? Because as I said before, with our disease activity scores or scales, they ask us to count the number of joints that are painful, but that doesn't take into account when a joint is painful but not swollen. And many of our patients to go on to develop either secondary fibromyalgia or just a chronic pain syndrome because they have so many pain conditions. So how do you deal with this moving forward?
Go ahead, Bets.
I'd like to know what her vector is.
Me too.
Yeah. I would agree that the vector in this case is probably my favorite tool as well. I have a patient just the other day who came in and someone had gotten her on, I think she was on over 200 mics of Duragesic and over 80 milligrams of oxycodone a day, and she still had terrible, horrible pain, and very similar story to the one I just presented. And the only way, because her sed rate and CRP were normal, that I could really tell what was going on with her was with a Vectra. And I, in fact, did a Vectra on her, and her Vectra was 48, which indicates that there probably is some disease activity.
Mm-hmm. Yep.
All right. And so with her congestive heart failure, are we worried about another TNF, or are we steering away from another TNF, or where are we at with that?
Yeah, so with congestive heart failure, you do not want to go near a TNF for sure. And plus, she's failed 2 TNFs in the past, so I am also not very interested in going towards a TNF in that situation as well. So what are your thoughts about which biologic, if you were going to use a biologic, if we determined that that's what we were doing next?
I'm actually a little worried about the methotrexate in her lungs. Can we get her into pulmonary and see if this might be a methotrexate-related ILD or something like that going on?
Yeah,
because that would sort of dictate which biologic we can use then, because some of them are okay monotherapy and some of them really work a whole lot better if there's some methotrexate on board.
Exactly. And the other thing is rheumatoid itself, especially when poorly controlled, can cause inflammation in the lungs and cause an ILD from that reason as well. So she would have to get to pulmonary in my case, in my mind. Mm-hmm. What do you think, Iris?
I'm leaning towards tofacitinib, also known as Xeljanz. Sorry, Scott. And just because of safety, and certainly she's probably a Medicare patient, so getting a biologic paid for is going to be difficult. And so I think compliance might be better. I don't know. I think that just may be an option for her.
So my understanding of tofacitinib is that it is very similar to the tocilizumab, which is Actemra, and that some of the concerns from a GI perspective are also present with the Xeljanz. or excuse me, the tofacitinib. So I didn't have it in the case study, but then when I was talking about her, I had remembered that she did have diverticulitis. So I might not be as eager to go towards that one. I was sort of veering towards perhaps Orencia or abatacept.
If you can get it paid for. My concern is with her Medicare, we're going to have to do an IV in the office, right, in order to get it paid for, and even then it might be a struggle, but certainly very, very, very safe.
It is, and it's safe on a couple of levels. So from the reading I've done, is it's safe from an infectious perspective, and certainly at advanced age with her multiple comorbidities, I'm always concerned about that, but also from a malignancy perspective, it has a little bit of a better profile as well. And with long-standing use of immunosuppressives, that's always something that's on my mind. And at 72, I'm also always worried about the skin and skin lesions, which we have to be careful of when we think about some of the TNFs as well.
Betsy, can you speak about the new JAK inhibitors and the cleanliness, and perhaps that we don't have to worry about perforation, or have you heard more about that?
I actually have not. I'm sorry.
No, but I did just read that they're the JAK1, right? They're able to isolate just the JAK1, which is the cleanest of them, and that one is, I think, just going into phase 3 trials. But that ideally should be able to avoid some of those problems, right?
We hope, yes. Okay, so tell us what you did with her, Christine.
Well, so there's some other issues with her as well. So I did end up putting her on Orencia, and she's been doing well, but her pain continues to be a problem. So I've had to manipulate some of her other medications. And so I got her into pain management and had them actually take her off of her oxycodone and start over again. So she was placed on Suboxone, believe it or not. And then we are slowly adding adjuvant support for her. So I think she was not on gabapentin at the beginning, and gabapentin is fantastic for chronic pain states, especially for neuropathic chronic pain states. So, and it might also help with her sleep. So we got her on gabapentin, and we've been slowly titrating that, and that's been doing well. And she is still on some oxycodone, but I'm sorry, on the Suboxone, but on a fairly low dose. I don't think with her degree of deformities that we'll ever be able to get her off, and we helped explain that to her. And then we've been talking to her about perhaps going on an SSRI because of her anxiety state, so that she maybe won't need to live on the benzodiazepines, which especially as you get older become more of an issue.
What I thought was interesting when you were going over her initial medication list was that her methotrexate was fairly low. Can you speak to that?
Yes, so that's what she came to us with, and and she had the history of elevated liver functions in the past, so I wasn't eager to go up on the methotrexate, and then we still have to work on making sure that the lungs are not affected, and it's never clear when someone's been on methotrexate and has had long-standing rheumatoid arthritis which caused the interstitial lung changes, whether it was the methotrexate or the rheumatoid arthritis itself. So at this point, we did not go up at all on the methotrexate, but know that it's there if we need to, in the back of our minds. If we needed to increase treatment, that would be something we could probably go on, up a little bit on. I wouldn't probably go more than 15 milligrams in this patient, especially because of her kidney disease. And I've seen a lot of kidney dysfunction with higher doses of methotrexate.
Well, regrettably, Christine, I know you fairly well, so I'm sure you started her on some kind of OT, PT, rehab plan.
Absolutely, and some other non-pharmacologic pain management strategies. One of my favorite things to do for patients these days, especially someone like this that's, has some mild depression and anxiety disorder associated with their condition, because it's just hard to live with the degree of changes that have happened to her over her years. So one of my favorite, very easy things to implement is to have patients make a list of 40 things they like to do. So a list of 40 pleasant activities. And they have to come back to me with 40. Because if they just make a list of 10 or 20, they don't really get into the meat of things that make a difference for them. But if they have to make a list of 40, they start thinking outside the box. And it makes them stop and really think about what's important in their lives. And I tell them to make that list big or small. It doesn't have to be, you like to go on trips to Europe. It can be that you enjoy a cup of coffee with your girlfriend, or you like to just watch the clouds move through the sky. And then I tell my patients, once they come back with that list, that they need to make sure they do at least 3 of those pleasant things every day.
Perfect. I like it.
It's so easy in our busy 15-minute visit with a patient to be able to implement that little tool.
Perfect. Thank you. What about a nice review, Betsy? Can you talk about treat to target, whether it's actually realistic for clinics, and what your synopsis of what we should do in the future?
Synopsis in less than 1 minute, because we're running out of time, is that treating to target is an admirable goal as long as we are measuring and staying in touch and aware of what's going on with our patients and having that shared and informed decision making. I think that's the bigger picture of the best way to treat.
Perfect. Thank you so much. Do we have any questions, Scott? Kevin? Scott? Kevin?
At this time, we're at the end of the broadcast cycle. However, what we can do is if any additional questions come in via Twitter or via any of the other mechanisms we've mentioned, and we also have on the rmsnurse.org website a contact us form that you're welcome to submit questions, and we can submit to our panel as a follow-up and get back with you. But are there any final remarks of any of our panelists? I think it's been a fantastic discussion, some great dialogue, especially it sounds like biomarkers are still very significant in the treatment of these patients throughout the lifespan as well. Are any final comments as we go around the room, Christine?
So I want to say thank you for inviting me, and I love that Betsy focused on the fact that we have to incorporate the patient. Thank you for that.
Awesome. Thank you, Christine, so much. Betsy?
Just also thanks for inviting me, and it's always nice to get together with other nurses and see what's going on around the country.
Awesome. And finally, Iris.
Thank you so much. It's so wonderful to be a part of this and to be your current president of the Rheumatology Nurses Society. Upcoming big conference in Cleveland. I'm hoping that Kevin's going to give you a little soundbite before we say goodnight tonight.
Sure, absolutely. So in Cleveland, Ohio, we have our 9th annual conference coming up, and you can find more on our website. It's August 4th through 6th. However, this is actually the first announcement of this on August 3rd. So the conference is actually going to be extended one more day, August 3rd through 6th. We are working with the IBEC initiative to where we are going to be offering a half-day free immunology boot camp with one of the faculty being Dr. Leonard Calabrese from the Cleveland Clinic, as well as Betsy Kirchner, who's on the broadcast tonight, and we'll have one other rheumatologist. It's going to be a half-day free immunology boot camp. Everyone's welcome. It is free of charge. It's going to be in the afternoon on that Wednesday prior to the conference. So as you're making your travel plans for the conference this year, fly in Wednesday morning, fly in Tuesday night. You don't want to miss that. And then, of course, we have our action-packed conference. We have we are pending somewhere probably around 18 credit hours. Take a look at the website. You'll see all the sessions and topics. It's going to be another banner year. We're exceeding our membership goals. We're exceeding our registration goals. And we just thank you because we're here for you, our members. We're here for you, the rheumatology healthcare professionals that are out there making it happen for the patients. So we thank you for that. Definitely sign up on our website for our newsletter. Sign up to receive that free copy of the Rheumatology Nurse Practice newsletter. Also, we have upcoming live education coming up, and that is our handling the hard questions, whether patients are asking us about RA. That is live, both dinner programs and also sessions. Our next one is in New York, the Big Apple. We're coming to the Big Apple on April 1. So that's April 1 at 9 o'clock in the morning, and we're part of the IAS conference pre-workshop. And the first 50 people that come to that workshop get free admission for the whole day of IAS. For more information on that, go to our website. Next, Philadelphia, we're coming to you on April 22nd. After that, Seattle, Washington, we're heading up there on April 29th. There's a possibility we may even hop up to Vancouver. We have a great chapter up in Vancouver that we're going to come up and visit, and then we're coming to West Palm Beach and Denver, Colorado. So we have an exciting 2016 ahead of us. Sounds like we have some great echo coming in on the audio as well. So thank you so much. Thank you, faculty and panelists. It's been a great discussion. This video will be available for replay on the RNS website, on our YouTube channel, as well as on Facebook. And we thank you for everything that you do for us, and we hope that this can be a resource and education to you ongoing that you can share with others. And we also would like to thank again Pfizer for the educational grant that we received to be able to bring quality education like this to you, our members and viewers. Thank you all, and everyone have a great night.